So here we are today with Jay Bryness, who is the Chief Executive Officer of Holyoke Health Center in Holyoke, Massachusetts. Welcome.
Great to be here, Dan.
Great to have you with us. I've been doing these interviews now for several days here in Chicago and going back to the Policy and Issues Forum to discuss the history of health centers. And the wonderful thing about that history, as you all know, Jay, because you've been through many years and many different experiences in the health center family, is that the story of each health center is unique unto itself. It is from the ground up. It's a local history. Yes, the federal funding and the Medicare and Medicaid payments, et cetera, came in and assisted and enabled you to achieve what you've been able to achieve at Holyoke. But Holyoke didn't get started out of Washington, D.C. or even out of Boston. It really is a local story, and that's what we want to evince from you, and also your own life in the health center family. And that's where I want to begin, because you've done some spectacular things over the years, including most recently with the delivery of goods and supplies to folks in Puerto Rico, assistance in getting some of them off the island after the hurricane hit, et cetera. What motivated you in the beginning to want to pursue a career such as what you've had with health centers?
I was started off a year after Woodstock. So since we were in the Woodstock celebration year, my wife and I were both at Woodstock. We weren't married then, but that's the era that I'm coming from. Okay, so my ponytail and my bell-bottom jeans and all that stuff. Finishing up college. And
so was it Jimi Hendrix or Stevie Nash that?
Jimi Hendrix, yeah.
Definitely.
Yeah, definitely. So, so New York City at that time, I was living in New York City, going to school, urban school, Hunter College, and finishing essentially my second master's, my master's degree in molecular biology. And
Molecular biology.
I was doing some work with the Red Cross and hemophilia sort of stuff, but I was disenchanted with the academic kind of structure that it had and the focus on writing papers and that kind of stuff.
Yeah.
And New York City was falling apart at the time. That was a low part of New York City. A lot of people sleeping on the streets, in bad shape, drug overdoses and things. Mm-hmm. And a cousin of mine actually had significant drug issues during that time. So I kind of started to realize, if I'm not going to stay in the heavy sciences, maybe I'll go in the public health end of it. So I switched into a health planning program. Urban health planning. Mm-hmm. And so I finished that, and my wife and I decided, she decided we're not going to stay in New York City anymore. It just wasn't comfortable. And we wound up in Vermont, of all places. And I started to work with the Vermont Public Interest Research Group. And I was assigned to start a children's dental health program for Montpelier, from Vermont kids. And the initiative behind this was this young guy named Bernie Sanders, who was a little bit less scruffy than I was, but was running on the Liberty Union ticket against the Democrat-Republican for governor. He observed, and his message hasn't changed in all the years he's been talking, the disparities in income and access to services. And he pointed out that this was the time that Vermont was developing into ski areas and second homes, and a fair amount of wealth coming into Vermont for second homes. But the farmers' kids were still struggling with no dental care. They were land rich but cash poor, and not a lot of dentists in Vermont at all, quite frankly. And so the kids were struggling, and Bernie identified that, and then the Democrat-Republican guys each one up, I'll do even better than Bernie will do, and so everybody was going to do dental care. So I was the dental researcher at VPIRG. Mm-hmm. So I said, put a dental plan together, because there's going to be a dental plan, apparently. So I wrote what became known as the Tooth Fairy program, and it was passed into law eventually at the end of that year after a lot of lobbying. And so all of a sudden there I was in developing health services, and it was surprising that I was in dental as well, because I never thought I'd be connected to dentistry in some way. Interesting enough, in my 40 plus years in the health center world, I've always promoted strong dental programs, probably because I cut my teeth verbally,
Sure.
pardon the pun, on that
And
issue.
it took the rest of the healthcare world and even the health center world almost 40 years to catch on.
Yeah, yeah.
So you were out there in front of the parade, leading it
Yeah.
a long time ago.
Yeah, and it was great to get involved with the government. Vermont's the kind of state, so when I announced my plan on the VPIRG, we knocked on the governor's door, walked in and said, "Here's the plan, Governor," because Tom Salmon was the Democratic governor who won. He said, "So you committed to do it, and we've taken the time to put one together for you, and here it is." And she could literally walk right into the offices. So politics in Vermont was very one-on-one, and it got me to be somewhat aware of how politics works and how you can get things done. So somehow I quickly got to a health center program in Plainfield, Vermont, which is now called the Health Center. It used to be part of Goddard College, and I was hired to be the executive director of the Health Center. And I've never been away from the Health Center since. So from 1976 on, I've been working in health centers.
Yeah.
And so interesting, I had this urban health background, but my life is now growing up in the rural health world, and which was fine. And a lot of things are not really any different, other than intensity maybe. So I stayed there for a while. Then I came to a rural part of Western Massachusetts. Worked at the Worthington Health Center, which was locally funded health center with some middle-class people that realized they had geographic isolation. It wasn't that they didn't have money, they just didn't have physicians in the area. So the health center was a way of attracting physicians. So I ran that for a couple of years. And I always had my eye on Holyoke as a community, which is 15 miles away from the Worthington site. And being a Brooklyn boy, Holyoke had a lot of Brooklyn characteristics that I liked. And I tried to move over to Holyoke, which I ultimately started in 1994 to be the CEO of the health center in Holyoke. And what's interesting about Holyoke, talking about diversity, it's at this point it has the highest concentration of Puerto Ricans of any community outside of Puerto Rico, by percentage, not by number.
Yeah.
New York City's got more Puerto Ricans than Holyoke.
Yeah.
But by percentage, it's an overwhelmingly Puerto Rican community. But in 1970, late 70s, when the health center was being founded, and even before the candidate that was the CEO before me, the job description that they were looking for was somebody who can be bilingual in English and French, because he was a French Canadian with a low-income population of Holyoke until in the 70s it started to transition. But in the 50s and the 60s, it was French Canadian, poor folks coming down from Quebec, working in the mills of Holyoke. There was paper mills and silk mills. So the health center always had orientation towards the needs of that community. And I think like the NAC movement, we need to change as the community changes. And I could just look at Holyoke. I wasn't there at that time, but when I first showed up, it was just transitioning into a Spanish-oriented community. But before that, it was French Canadian, low income, and before that there were Italians, before that there were Portuguese, and so
Sure.
so it was always an ethnic wave coming in for whatever the issues were that the economy required or the economy supported. So the opportunity to slide into Holyoke and to have this very eclectic kind of community that's now going Spanish, but it's still on up and rising. There's a lot of endemic racism in the community. The old fathers of Holyoke were the Irish. That was the founding group. And they didn't want those kids in these schools with our tax dollars. And so the investments started to dry up. The Irish kids were going to the Catholic schools, and the school system fell apart. And so it's 25 years later, that's what I'm dealing with still. Nobody remembers the French Catholics at the time, although one of my first nurses that were hired by the health center before me was Donna LaRock, a French Canadian woman who still works for us today. So she's
Seriously?
she's in
Wow.
her she's about to retire. Anyway, so I think we're still working with the population growth. And the other interesting thing about Holyoke, which sets me apart from a lot of my colleagues, is that we have the strong diversity and cultural identity of this Latino community, but they're all Puerto Rican, which means they're all citizens. So we don't have some of the issues of undocumented, although we're seeing Central America, other communities migrate in more and more. But we are a sort of a pure play, U.S. citizen health center driven program, and we don't have to focus some of our energies on some of these other important issues because we don't have as much of that. But we have a lot of poor Latino communities that we have to serve. And I think that's what our commitment has been, to improve services, improve outcomes, and engage ourselves in the community in every way possible to make that happen.
Let me ask you, let's go back to Vermont, the early days, Plainfield, and then even in Worthington. What did you take away from your experiences there in terms of the importance of the health center to the local community and your work and your focus while you were there?
Every site is unique, as we all know, and there were total different dynamics at work at each of them. The Plainfield community truly was a grassroots effort. It's the most grassroots effort I've ever seen. And there was an infirmary at Goddard College taking care of the kids, the small number of college kids that went to Goddard, a small college. And yet you had the farm families in the area that didn't have access to health care. But these kids that came up to Goddard, we made sure there was a doctor on the campus for them.
Yeah.
So the progressiveness of the Goddard College community said, this isn't fair, we need to open up the infirmary to the community. So the infirmary was opened up to the community. So we really started, I got there, I was hired, we were still contracted to work for Goddard College, but we were moving away towards independence from the college. The college was having financial difficulties, we were growing, and everybody was going in different directions. So the health center in Plainfield, true democracy was the board of directors, and they may or may not pass muster with 330 guidelines today, was elected by 6 towns. Each town elected 2 board members, and that's who the board of directors of the health center was. So it wasn't even anything that we in the health center could control. The municipalities, the way our charter was set up, would determine who our board members would be. So we could have 0 users of the health center as the board, or we can have 100%. We never knew who was going to be our, depending on how the elections went. And so it got us to talk to a lot of community members, some of whom are just, they ran for the health center board because they wanted to do something in town, these small rural towns, and and it was a good thing to do. But they weren't necessarily looking for health services, they weren't patients. And others were definitely looking for health services for themselves and their kids. So the board there was very, I use the word powerful, but not in the sense of exerting themselves, more because they really connected to the community. They really truly were elected by the community. It wasn't elected by our own board, re-electing board members. This is, we read the papers and went, who our new board members are,
Yeah.
So it was interesting, it was fascinating. And early on, we then built a building there, and one day I got a knock on the door, and I wish I could remember his name, but it was early National Health Service Corps staff member whose job was to go out and find places to put these doctors that were now having National Health Service Corps pipeline issues. They're coming out next year, and we don't have enough places to put them in yet. This is a brand new program. So they knocked on my door and said, we've got these opportunities, and would you want to participate in it? We were in a 330 health center, and it was early in the health center world up there in Vermont. But we said, well, I already have doctors. I don't need any new doctors. Can I put the existing doctors into the Corps? So we got them into the Corps under the loan repayment kind of program. But then I said to him, but what I could use here was a large animal veterinarian. You got one of those in the Corps? Because the farmers were all saying, we got these cows and horses, and the health center had a field right behind it. We could literally have a barn of animals back there. So we almost opened up probably first community health center veterinary site, but we didn't do that. So, but the National Service Corps, their job was to get more access places, and if they had to put a veterinarian here just to get you guys into the system, maybe we'll do it. So, so they thought about it, but it didn't come to be. So that was Vermont, and then when I got to Worthington, it was more of a bedroom community of the 5 colleges in Pioneer Valley of Amherst and Northampton, Massachusetts. Still farm-oriented to a certain degree, but less based on the farming economy and more on just surviving in western Massachusetts. So a lot of people would live in the hill towns, Worthington being one of them, and get up in the morning and drive to UMass or Amherst College or Smith College and go to work. So we had a very educated residential population who wanted standards higher, the highest standards possible for healthcare. That's what they come from, that's what they expected for their family, and that's what we were directed to deliver. And we did, I think, as most health centers do. We deliver great care. But that was a community that was more looking to be maybe not in control of the health center, but to be in the management process of the health center and more closely, because they felt they were all managerial level people of themselves and they could help us manage it. And we actually had a very small staff. So in a lot of ways, we appreciated their support and assistance. So it was a very close working relationship with that community. And the health center, eventually we opened up a second site in Huntington, which is 15 miles away. That site was a totally different socio-demographic portrait. It was totally blue collar, higher unemployment rate because the paper mills in that time were starting to close and move out of Massachusetts.
Yeah.
And so the people that were working there were out of work. Alcoholism was an issue. Different caliber of need and population. So within our two health centers, one in Worthington, one in Huntington, it was a total different need-based service mix. We had to treat these people with a lot more Medicaid and a lot of more alcoholism and substance use issues, and the Worthington side was kind of Blue Cross Blue Shield and traditional family healthy stuff. So it was an interesting concept to run it as one system. And the money was up in Worthington. There was some endowment up there when they first got started. So they were not too happy about opening up this health center in Huntington because it wasn't their people. So very provincial. So from that, I wound up going to Holyoke, and it was a totally different scene because almost all of our patients, or all of our board members, are really connected to the Latino community in one way or another. And the whole perspective of what is appropriate, what they need, how they can deliver it, what the difficulties are, the transient nature of people coming and going and losing housing and being evicted and having kids with social problems. Just was different intensity that was kind of interesting.
Yeah.
So,
and you took all of that with you now. I mean, you took all of your experience from Plainfield and Worthington to Holyoke. What did you encounter in Holyoke that was unique and different? You said there were a lot of things in common, but there were, I'm sure.
Well, you know what? So I can even remember in my interview to become the CEO of the health center in Holyoke, I was coming from a, can-do health centers. We're going to take over the world. Primary care is the answer. You guys are running a primary care center. And the experience that they had in the last few years before I got there was sort of a failing health center. They were not doing well. And I think they were not confident that it could work in Holyoke. And I said, no, you got it all wrong. You've got a lot of needs, and people want to work. We can make this a great place, and primary care is what we're all about. And so I entered Holyoke as a cheerleader, which was not my role in the two previous health center jobs. And I just said, you guys have to get behind this issue and have some confidence, and we're going to grow it. And we did. We've grown from, when I got there, I think we had 30 employees, and today we have about 330 employees. So it was grown
Big
significantly.
difference. Yeah.
And I think we are, I've had my family members treated at the health center. I encourage everybody to come. It's the best health care in the Valley. We've got some big medical centers nearby with wonderfully trained and skilled clinicians, but they don't have the health center orientation. They're not looking at the patient-centered issues. They're not looking at really providing what the families need. They just do their work and ask the next person to come on in, right?
Yeah.
So I think we truly have shown them, and I think the area has appreciated Holyoke does have, there's a center of excellence in Holyoke, and I think we are recognized in the area by these other centers, and we've been successful in recruiting some of their providers to come work for us, and when we've interviewed, and they've been interviewing there and with us, we realized we're going to get our fair share of those interviews, even though the bigger sites have some additional benefits and some more stature, but we're going to get the people that really want to do the people's work, and they're going to come to us, and they're going to feel good about it, and they're going to deliver great care, which we've always done.
Well, and it is a much more urbane community than the others that you were in, but it's still, it's not Boston,
Right.
and it's not New York City. You must have faced some difficulties and challenges in recruiting staff, retaining staff, and as you expanded services.
Yeah, we've had
to-
some ups and downs over time, and staff sometimes come in waves too. They, all of a sudden life happens to a couple of different families in different times, but they all wind up leaving, and we have to go out and hire quickly. And while we're hiring, the burden's on the docs that are there and the nurse practitioners. So we've had those issues. I'm happy today, as we're sitting here talking, to say that we are almost in a surplus of primary care providers at the moment. 2 years ago, that wasn't the case, and 2 years from now might be the case again, that we will have shortage of doctors. But right now, we're actually recruiting really well, and we're doing some great stuff. We've got great services now that bring the doctors in. So we have one of the best pharmacies in the country, I think, at the Holyoke Health Center. We announced that we started a pharmacy residency program. We have robots. No, it's
your own.
Yeah, it's our own.
Wow.
They match to us. We've got a whole system of robots. We started a delivery system with couriers that are delivering meds to patients' homes who can't, especially the older folks who have, 10, 15 meds and they keep running out and they can't keep, it could be a mile to get to the health center and it could be February, it's wintertime, it's hard. So we want them to stay on the meds that they're supposed to be on, make sure they're paying attention, good adherence. That stuff then helps the doctor say, you know what, if you can make sure my patients take the meds, my job as a physician is easier and more rewarding because we're seeing improvements in people's lives. So I think things like putting a pharmacy in place that's state of the art and is leading the way, and we've gotten lots of recognition for integrating the pharmacy on each of the teams. They huddle once a week with the teams and they integrate everything. Can't come out of the hospital and back into the health center without stopping at the pharmacy and having a med review before you go back to the doctors. So pharmacy has become integral to everything we do. And I think the doctors today would quit if the pharmacy closed. I think it's that kind of like it's incredible, and you're not going to get that from the CVS, Walgreens of the world. It's a volume game for them. It's how many meds can I sell and how many bottles of shampoo can I sell. We're just basically making sure the patients are adhering to the medication they're supposed to get. So I think that's.
And is the pharmacy? Does it service only the Holyoke patient population?
No, we have both the retail license and a clinic license.
You do?
So with 340B, we are people. The mayor can walk in across the street from City Hall and get his meds filled with us. It's open to anybody, and we
as well. It should be in a community like that. You really want to integrate.
And we are the only pharmacy downtown. Because interesting, when we built our building, which was an old building that we were early on. I worked a lot with Allison Coleman and the Newmarket tax credits and historical tax credits and federal loan guarantees to get funding. We needed about $20 million at that time to put the health center together. And the local banks were saying, there's not a building downtown Holyoke worth $2 million. Why would we loan you $20 million? So, the low-income community there's no value.
Sure.
You can put all this money into it. They can see the money that you're putting in, but if I sell the building from the bank's point of view, there's no value in it. So what's the guarantee? So we had to get the loan guarantee, which was critical, and we used Newmarket tax credits and did all kinds of things to put a building together. The building that we bought was a big old department store in downtown, right across from City Hall. It was a cornerstone, flagship almost of downtown Holyoke. They had now gone out of business and closed. And there was a furniture store operating out of it, and this guy was in his 80s. He was about to close. You were about to get the big white elephant building in downtown Holyoke. It would be boarded up soon, right across City Hall. Nobody was going to have the Holyoke. So we really were the first thread of redevelopment of downtown Holyoke. We put a lot of money into that corner. The building housed, before we got there, a Rite Aid pharmacy. They closed because they actually left the whole state of Massachusetts, the whole Rite Aid chain. And the guy that owned, Mr. Epstein, who owned the furniture store, said, if I could have put a pharmacy back in there, I would have never sold my building to you because that was enough income to make my building work.
Sure.
And we brought our own pharmacy in when we opened up the health center. And he said, how did you get a pharmacy? Because he said, I asked every pharmacist, can you come open up a pharmacy? It's already built, just replace Rite Aid.
Turnkey operation.
The volume was there, don't ever even know they switched names. I said, well, Bill, you selling lazy boy recliners and so forth. I've got 20,000 medical patients. It's easy for me to open up a pharmacy and make it work. You couldn't because you didn't have the concentration. So we've maintained that pharmacy commitment almost as a heritage, lineage kind of issue for us. And we've also done a great amount of work in dental care. So we now have 8-person pediatric dental residency program. So going back to my days in Tooth Fairy in Vermont, it's like I need every kid to have a dental home. Not just a screening by a franchise or a school
Right.
hygienist coming
Here
by.
today, gone tomorrow.
But I need a dental home for all my kids. And there are no pediatric dentists really available. And the ones that were available didn't want to see Medicaid kids. So we had to do our own. And so we were able to start a residency program originally with Lutheran, working with that system, and now it's part of the NYU system. But we are taking kids into the OR for severe cases. We're working with cleft palate issues with Shriners Hospital. We're doing incredible work. Shriners now wants us to open up a dental clinic in the Shriners Hospital because they have a fair amount of
Really?
the cleft palate clinic
yeah.
is very intense. So we've grown dental to be probably one of the largest dental practices in the state of Massachusetts because we've added residencies, we've added adult kids, we have surgery, we have endodontics, we have everything. So on every level, I think the health center has achieved almost the highest level of service delivery that particular issue requires. Pharmacy, we're top of the game. Dental, I think we're on the top of the game. Medical, we're definitely on the top of the game. And I think the people in Holyoke feel very proud that we are their health center. There's zero graffiti on our walls. We've been there for 15 years now, and I think that's the respect of the community saying this is our health center, and we're going to keep it looking good. It's an urban core. And that's why when the hurricane hit, we watched it come on the news, and it didn't have the full impact until you heard how severely it hit that island. And my entire staff, I'd say 90% of my staff were Puerto Rican. So my staff were, where's my mother? Where's my brother? All their
back
relatives
on the
back
island,
on the
huh?
island. Like they can't, no phones, no
And this
internet,
was when?
nothing.
How long ago?
It's a year and a half, almost 2 years now.
Yeah.
September 20th of 17. So, and we had patients who were almost all Puerto Rican, and then everybody in the community, even if they weren't our patients, the community was basically Puerto Rican.
Sure.
So Holyoke was like, the hurricane hit Holyoke, even though we were thousands of miles away. And so we realized we had to do something. Nobody knew what to do, quite frankly. It was like, whatever you can do, do. And we were able to get through a local city councilor, who was a friend of mine, who knew a local Puerto Rican pilot who was working for like American Airlines or something. And we were able to get a private jet donated to us through like one of these, I put my jet on call and I get a tax write-off.
Yeah, like a Gulfstream.
So we flew down in Gulfstream, and I said to the people flying us down, "Whose jet am I on?" They said, "We can't tell you. We're not allowed to tell you." So I don't,
You still don't know?
Could have been the Koch brothers. I don't know whose
Yeah,
jet it
yeah.
was,
You know what? Who cares?
Yeah,
If they were willing to do it.
I'd like to thank them. Basically,
Yeah.
I'd like to say thanks for donating it. And so we flew down, stacked to the gills with supplies and materials that us and others had been assembling, but we brought it all to the airport and loaded it up. And we came back with, a group of primarily older people, and a couple of grandparents and grandchildren of like, the parent was behind trying to figure out what to do with the house, but they sent the kid and the grandparent family back north, get out of here, go get some safety. And, a couple months later, we never stopped taking people in. So we had a couple of flights of our own, but then they started boarding the commercial flights, and because Holyoke had a big population of Puerto Ricans, it was a natural draw of people leaving the island. We grew by 1,000 patients that year of evacuees from Puerto Rico that became Holyoke Health Center patients.
Wow.
And most of them, we believe, are still in the area. They're not all in the health center because once they got here, they were doubling up and tripling up with people. And Holyoke is a small city, couldn't accommodate that kind of load. So they started getting housing wherever they can get it. So they're living someplace in the area, but not necessarily in Holyoke. And as a result of that, we've got this nice new relationship with everybody on the island because we met a lot of the health centers down here, and now it's a bridge, between the health center.
Without a doubt, a superhero. Yeah.
Yeah. Well, it's just even like what can we continue to do? So we're now thinking. It's not yet set in stone, of bringing a pediatric dental rotation down to the island and going to the health centers and providing pediatric services.
Wow.
For those who don't have good pediatric dental access, or general dentists who are doing pediatrics, but they love to get some support by other people
Yeah,
who've been
sure.
trained specifically, and then maybe they would train the trainer kind of thing, and
Yeah.
they'll start to do more of it on their own. So I think the Holyoke Health Center now is a great place to say, we've been with the movement for a long time. We've seen the changes go. I used to say to people, when Romney Care came, people say, that must be impacting you a lot. And I said, no, because we're all on Medicaid. we're below the radar. So when Romney Care brought more people into the system, all of our people were already in the system. So it didn't really affect us much. And then when Obamacare came, it was the same thing. Holyoke continued to operate because we didn't bring
Same thing,
We were pretty much a single-payer system back in the 70s. Between Medicare and Medicaid, almost all my patients are covered.
That was it.
So we have a lot of insured population, and the Puerto Rican population was a more difficult one because they would leave the island with Medicaid and they didn't want to give it up when they came north, because then when they went back home, because they'd fly up for the seasons.
Sure.
When they went back home, they wouldn't have Medicaid anymore, and they'd have to get on the back of the line and wait a year or two before they got Medicaid.
Wow.
So they'd come north with Puerto Rico Medicaid, which we couldn't bill. So we would basically do free care for those folks.
Oh, boy.
They were insured, and if there's a big problem, they might fly back to Puerto Rico, maybe
Yeah.
have it treated down there.
So they wanted to hold on to their Puerto Rico Medicaid.
Because it was,
ASIS,
they
whatever
were
it was
still
called.
basically Puerto Rican residents, and that's where their home was, and that's so while they're visiting the north, like in the summertime, they left Puerto Rico, and some of the kids would come north and stay with relatives, and then in the fall they'd go back home. They would face no Medicaid down there and not a lot of good access to care. So to them it was more important to hold the Medicaid in Puerto Rico and get free care from us in Massachusetts.
Yeah.
So they learned how to play that game appropriately.
Maybe a bit unfair, but I can also understand wanting to hold on to something that they have.
We dealt with it. It's like that's life, and that's what we're getting, and we got to make that work. And so it was frustrating at some times, but especially the years we had some bad financial years, and like, it'd be nice if we got some of that revenue from Puerto Rico Medicaid, but it was what it was. I think we're always happy to be able to serve it.
Has the island sufficiently recovered
Not
from the hurricane?
no,
Not at all,
no.
huh?
Well, there's the hurricane, and there's economics of the island, which was, a basket case before the hurricane, and so that's just gotten worse.
Now it's a political basket
Now
case.
you
too.
got politics, economics, social, and weather, climate. It's really. So far, we're all thankful that another significant storm hasn't hit the island since Maria. Although in talking to my colleagues down there, I think they all have much better investments in solar roofs and other kinds of issues right now. And I think the health centers down there have now, as a result of the work that they did after Maria, the health centers in Puerto Rico, their stature has been enhanced because they remained operational throughout. Some were closed for a couple of days and then they got back, and some of the staff had their own staff, personal problems, and everybody had to deal with things, but the health centers continued to work. So when we flew in a week after the hurricane, we were able to go to health centers that were functioning. The private sector all bought a ticket on Delta and they flew to Miami to wait out the hurricane, and they thought they'd be back in a couple of days. So they left, and then there's nothing to come back to, and they couldn't get flights back. And so the private sector basically was dismantled. Little by little, it came back, but it's not as big today as it was before the hurricane. So I think you have a smaller private sector now, and more reliance on the health
centers themselves.
And I also heard some of the health centers tell me that they've had the private docs come back and say, "My office is closed. There's no water, no electricity. Can I work for you?" And some of them are now working at the health centers, and they've never gone back to open their offices.
Wow.
It wasn't. So I think there's a shift there, which was interesting, and I think. It's a smaller population now by size. The economics, I don't think, are any better. I think there's a little bit better infrastructure. There's some federal grant dollars and HRSA dollars, I think, that have gone into Puerto Rico to help them invest. And I think I'm expecting that they're using those dollars wisely. But, the definition of an emergency is like you never know what it's going to be and when it's going to come. And so do we invest in the right product? Well, we thought it was a hurricane. Maybe the next thing is going to be a snowstorm. Who knows? I don't think Puerto Rico is going to have a snowstorm. But,
wow.
But I think, but our relationship to that process, and I can say our staff, my medical director, Dr. Esparza, immediately put the call out that, Puerto Rican families are coming north. We have to make room for them. And we put on evening shifts. We did all kinds of things to make room, to make sure that we didn't keep our existing community patients from getting into services while also having room for these new people who were our guests at that moment.
Yeah.
We didn't know what was going to happen with them. So I think the whole staff came together. And I think the pride that our staff had that we were responding to the hurricane was very visible. I've never seen them walk around that way for anything before or since. They actually felt a health center up here in Massachusetts will help another needy population someplace else in the country that we can relate to. And not only are we taking good care of ourselves up here, but we're taking good care of our family members.
Spirit of giving,
else.
yeah.
And I think it was, a sense of accomplishment, pride, humanity. I think all the good feelings for the right reasons all came out. And I think I think we're building on that since. There's some evaluations going on right now, and I've got these evaluators from various universities that have been doing studies on how does a small place like Holyoke take in so many people. And what they're saying to me is, you've saved lives. I mean, we've heard from people, that they've told us if it wasn't for A or B or C. And I know some of the cases that we may have had that kind of impact. I didn't know some of the other ones that, and they could be proverbial, to save my life. But I think it's helped the health center bring the awareness to the larger community that this is an issue, the type of issue that a nonprofit organization like a health center can lead on. And we need to look to these guys for leadership because the hospitals didn't do it. My local hospital said, I'm just a small community hospital. I can't help these Puerto Rican people. And I said, but they're getting off the plane. They're coming to Holyoke.
Yeah.
They will be
what
in
are you
Holyoke.
going to do?
You can't
You better
respond
get ready.
like that. Let's work together. He felt that the federal government has to take care of that. So I think that also changed my feeling about working with some of the local health resources because I realized that they were never going to understand what we're trying to do.
Yeah.
And now we're in our wonderful ACO, which now puts us in a different relationship to these hospitals because.
Oh, you formed an ACO?
Well, we're part of the Community Care Cooperative.
Oh, okay.
It's got Manny from East Boston. It's got Brockton. It's got Worcester. So we're 18 of us now are in an ACO.
Wow.
And no insurance company, and no hospital. So the entire ACO structure is based on primary care, and we're working closely with the state Medicaid program. And I think it's another sense of the health centers kind of growing into their own, and we don't need these other structures, which are really just, you need hospital care at some point, but you don't need it to be driven by the surgeons and by the high cost issues. You need it to meet the primary care needs of people. And we certainly can manage our own fees, so we don't need an insurance company to tell us we can or can't send a patient to the hospital, without prior authorization or something. So we are now at full risk for our patients. The state is giving us data on risk issues and cost issues and targets, and if we do well in
You get a
managing
per
the
capita
cost,
payment, do you?
No, we build the Mass Health system on a fee-for-service basis as if nothing changed. We didn't have to build a network of providers because basically everybody in Mass Health in the state is the network. So I could send a kid to Boston Children's if I want to, and I don't need to ask the local hospital for prior auth to send them. Not that we can do that a lot, but we're totally flexible about where we're going to send patients to as long as there's a Medicaid program at that site. Any specialist that takes Mass Health is in our network. So we don't spend any money on network development and marketing like that. And I think the state's giving us targets, and so it's at the end of the year, $700 per member per month, whatever it costs. And if you could get it down to $500 or $600, then there's money to be split between the state and the health centers. So we're at that point. We're just starting to see the results of 2 or 3 years of putting it together. We're taking care of patients. We are staffing up for the new approaches to some of the care issues. We've hired staff that we've never had before in nurse complex care management and in data management and population health. So all 18 of us meet. We're board of directors, 2 people from each health center, and that's how we make all of our decisions. It's a pretty equitable model, and we all have a role in the decisions.
So you're going to test the theory that if you invest enough in the well-being of the people you serve, there can be a robust return in the form of reduced costs and shared savings.
And I think what we would love to all get to is see enough of these savings available to us quickly that we could invest back in the social determinant issues as well. So can we build housing in our communities? Can we improve the school systems? Can we do
Sure.
things that are going to make our patients healthier and drive their costs down because they're going to be living a healthier life? And all of us are excited about that. Each of us in each community has probably a different focus of what they'd like to do. I've actually had a strong focus in education. I started a charter school in Holyoke about 10, 15 years ago. And I'm committed that the kids in our community have to be so well cared for in every level that they will have middle-class futures ahead of them, and they'll get out of poverty. And if they fail in school, they're going to be sick their whole life because they're going to be poor their whole life. And if they're sick their whole life, and I'm the healthcare provider on basically a risk basis, that's
You're going to have a bear
so I've
end of
met with the
life.
superintendent of the schools, and I said,
Yeah.
you know what, your students are my patients, and if you don't get them a good education, I'm going to be paying the bills for a long time. And so we have to work together. And so I think those kinds of investments is what I'm looking forward to. I think we can pull our clinical staffs together, and I think we already have what we need. I don't think we have to do too much more. But once the returns start coming in on the preliminary investment, I think now how do we take the dollars and bring about the secondary line of investment in the community, which I think will be the long-lasting impact then. Because
That really is.
Yeah.
That's the
get a kid out of high school into college maybe, that kid's going to be much better off than a kid that
that's
dropped
the
out.
golden cup.
The 15-year-old
It is.
dropout is going to be a problem for society for a long time.
That's right.
So I think, we've got an opportunity to kind of roll it forward and play it forward and help the systems. And hopefully at the national level we'll see some sanity in how healthcare is funded and provided.
Don't count on it anytime soon, other than what we're able to accomplish.
Well, I think we're doing our own, which is why we're so happy that we can succeed without the insurance company, and the hospitals are not taking the district and giving us a portion of the district for our needs, but we're actually getting all of the district and figuring out what we want to do with those investments.
Yeah.
So I think we are, at least in our ACO, showing that we can be trusted with the tools and the resources, and with the mission of improving health. And I think the state has been a big supporter of ours. They were a little nervous at the beginning. Could you guys really pull this off? We want Blue Cross to do it. We want the insurance companies to do it.
Yeah.
And we said, no, we think we could do it. And I think at the moment we're the largest Medicaid ACO in the state. So we have more members in our ACO than any of the hospital systems have put together. So I think that's great. I think it just
Even
showed.
bigger than Mother General, huh? Mass General.
Yeah, I don't know what their Medicaid ACO size is like. Some of those health centers that feed Mass General are in our ACO.
Yeah.
And so they've had to make decisions about telling the hospital, I'm not going to be in your ACO, I'm going to be on my own. So,
Interesting.
So we've, and some folks have had, the hospitals have said, you can't get out of my ACO because I need you, and because I fund this or that for you, I won't let you go.
captives.
So yeah, we've had those issues. So when I think of where I am right now, and I'm kind of thinking about the retirement process, but I think we've come so far along so many spectrums, and the different communities that I've been in. At the end of the day, healthcare is healthcare. You could be rural, you could be urban, you could be really starting from scratch and building a new system or taking over an existing system and trying to move it along. I think if you bring in the good providers and you have good mission focus, the community will respond to it. And I think our national movement has really led the way and will continue to lead the way, because I don't think there's anybody out there coming close to doing what we're doing, commitment-wise, vision-wise, and I think our success is, I think, going to do us well for the future. And we can get through the rough spots when they're, because we do hang together, and I think that's great for us.
Yeah.
And after the rough spots, I think there'll be progress.
So you are bullish on the future for health centers.
You know what? I think the whole national movement has proven it. What we're doing in our little ACO is very much more intensifying the outcome, the possibility, testing what can really be accomplished. So we've done it. on small scale, intense, and on the broad scale. And I think, as you're aware, I think there's so many legislators out there that know that we are the answer, and
Yeah.
they have no plans. There's no plan out there other
No,
than
that's true.
what's happening right now. And every year that goes by, I think we're stronger, and so we become the go-to, and we're no longer the upstarts trying to show the world
The
that
future
there's a
is
difference.
ours.
We are now there. Yeah.
Jay, thank you so much.
yeah.
Thanks for your lifetime commitment.
Well, and you too.
this
and you
system of
too.
care.
You know,
Yeah.
we'll go out in the sunset together. Enjoy it.